All right, so we're going to get started in this session. I'd like to introduce our speaker. Dr. David Zagzag is a professor of pathology and neurosurgery at NYU School of Medicine. He's the chief of the neuropathy division at NYU Langone Medical Center, the director of the Human Brain Tumor Bank at the NYU School of Medicine, an underachiever, and the director of the microvascular and molecular neuro-oncology lab at NYU Langone. Among several awards he's received in 2006 and 2008, he was named Teacher of the Year at NYU School of Medicine and was granted New York University's Distinguished Teaching Award in 2010. As a committed researcher in the field of neuro-oncology, he devotes his research efforts towards, nice word, elucidating molecular mechanisms linked to angiogenesis and invasion in gliomas. Dr. Zagzag has been the principal investigator of several research proposals funded by private foundations, the American Cancer Society, and the National Institutes of Health. Throughout the years, he has published over 200, you are an underachiever, 200 peer-reviewed articles, reviews, and book chapters. He's been invited to lecture at many national and international meetings, especially, and most preeminently, this one. Please welcome Dr. David Zagzag.
Thank you very much. I'm very proud and honored to be here. I once listened to a talk Judah Folkman gave, and after the person that introduced him spoke for about 10 minutes, Dr. Folkman said, "My father would be very proud of this, and my mother would believe it." So thank you for having me here. I have to say, having signing out a pathology report for the last 25 years, this lecture was quite a challenge for me, because here I was asked to explain my report, and it is true that the words that we use in making a diagnosis, describing the tumor, might not be words that could be understood by everyone. So my challenge today is to achieve such a goal, and I hope that at the end of the next 35-40 minutes, you will be able to understand what is in the pathology report. So I have 4 parts to this talk. I will describe to you what I consider is the role of the pathologist. Then I will illustrate for you what are the WHO, World Health Organization, features that allow us to grade a tumor, and then basically show you examples of what is in the pathology report, and of course discuss the impact of the pathology report on how the patients are managed. And I'll spend some time discussing molecular tests, and I think that it is essential that these tests are part of our neuropathology examination, and I think those play a major role in how the patients are managed. So how do I see the role of a pathologist? First of all, it's obvious that our primary role is to determine what type of the tumor patient, what type of tumor the patient has, and what is the grade of the tumor. But I also believe that more and more doing this molecular testings that we are referring to over the last 10 years is essential. Essential because it will help tailor therapy for the patient. I also believe that it is critical for us to help in facilitating and supervising tissue banking. And what we mean by this is that when the surgery is performed, a piece of the tumor is taken and frozen away. It's done for several purposes. Sometimes it's used for research. Sometimes it's used for tests that can be done in the future when novel therapies are identified and the patient and the family are interested to find out whether an antigen or a protein is present. And this might not be possible if that has not been done. I need to say that for me, the most important role as a neuropathologist is to determine with certainty whether the patient does or does not have a brain tumor. And we heard about pseudoprogression. We heard about demyelination. Dr. Landolfi just mentioned that he had a case where he thought this was probably demyelination mimicking brain tumor. So I would like to take one moment to show you this example in answering this question. Is the lesion seen on the MRI a brain tumor? And with all due respect to our colleague neuroradiologists, neurosurgeon, neuro-oncologists, we have seen over the year patients with MRI abnormalities which were read as neoplasm by the radiologist, would turn out to be something else. So I think it's an important step to make sure that what the patient has is indeed a brain tumor. And here are some examples. And I would ask you, which one of these is not a neoplasm? It's quite complicated because they all have the classical features of a brain tumor. They are enhancing, they are causing what we call mass effect, shift of tissues, and clearly it's important to know which one of these is not tumor. I don't have the time to discuss all the 6 cases, but one of this turned out to be pseudoprogression, and when the patient was reoperated, the pathology showed that there was no tumor regrowth, but pseudoprogression. This was the case I chose to illustrate for you. This is the case of a 26-year-old that had an endocarditis, which is an infection of the heart, and because of that had a brain abscess. And so this illustrates very clearly that you have to be upfront able to suspect that maybe the tissue you're dealing with is not neoplastic and maybe it's something else. So that's essential. Now, once you have established that it is a brain tumor, these are the list of pathologies that can mimic brain tumor. They are infectious, there could be bacterial or fungal infections, demyelination, inflammatory disorder. There is a long list of cases, and we, throughout the years of the last 25 years, have summarized our experience with conditions that are not neoplastic, mimicking brain tumors. And this is a recent paper we published. Now, once you have determined with certainty that you are dealing with a brain tumor, the goal is to establish what type of tumor your patient has and what is the grade. So what do? We first establish what are the cell types. And this is a Kodachrome here, an image where you can see that there are some large cells who have the features of neuronal cells, the cells of the brain, the large neuronal cells, but also cells that are smaller that have the features of astrocyte, supporting cells. This is a tumor that has a mixed profile, both astrocytic cells, but also neuronal cells, something we call a ganglioglioma. And on the right, you can see that we have a large battery available to us of immunostain that allow us to confirm that indeed there are cells that have astrocytic features because they are GFAP, and you'll see that in the report, GFAP positive, but also cells that are synaptophysin positive, which is a neuronal marker. So in such a case, you determine the tumor has both a glial and a neuronal component, and you can confirm that by doing special stain such as immunostain. We then include in the report things like cellularity. What is cellularity? Cellularity is how the cells are crowded. On the left is a normal cortex, not neoplastic. Here is a lower cellularity, and here is a high cellularity. Tumor cells crawling on each other. This is what we call a highly cellular neoplasm. Of course, these tumors are more aggressive than this tumor. So when you have a highly cellular tumor, it is likely that it corresponds to a higher grade. But the WHO has 4 defined criteria that is used to determine the grading of a tumor. These include necrosis, which means cell death. A necrotic tumor is usually of higher grade than a non-necrotic tumor. Mitosis, which is cell multiplication, proliferation. The more proliferating cells are present in the tumor, the more malignant the tumor is. Nuclear pleomorphism, cell morphology. I will illustrate for you all these features in a moment. How the tumor cells appear and how they compare to each other. And then, of course, microvascular proliferation, which is known as angiogenesis, at least in part, which is the base, of course, for the Avastin treatment. So here is a slide showing on the bottom cell death, which means necrosis, and the viable portion of the tumor. This row of cells here is what we call the pseudopalisading cells. And you've seen this in your report. The section shows necrosis with surrounding pseudopalisading. This is what we are referring to, this row hypercellularity at the edge of necrosis. Mitotic figures. Here's a tumor that has at least 2 mitotic figures pointed by these two yellow arrows. But we have developed over the year markers of proliferating cells. This is something that you'll find in your pathology report, which is called the MIB1 labeling index. These are cells that are actively proliferating. And for those that are interested in what we call the cell cycle, these are not in G0 phase. So all of these cells that are brown labeled are actively multiplying. Nucleopleomorphism. Are the cells identical to each other, or are there significant variability in their appearance? Here's a huge, gigantic tumor cell, intermediate size, and then smaller tumor cell. This is a tumor that is highly pleomorphic. And of course, angiogenesis, neovascularization. In fibrillary astrocytoma, angiogenic tumors are more aggressive than non-angiogenic tumors. And here is an example that depicts very well the marked vascular proliferation. These are not tumor cells. These are vascular cells. The cells in between are tumor cells, and you can see that in some cases, the vascular cells are even larger than the tumor cell. This is obviously the basis for the anti-angiogenic therapy that is best exemplified by Avastin therapy. And we have tests in the lab, again, that allow us to highlight specifically these endothelial cells. This is a stain that's called ERG, and you can very, very well demonstrate that the tumor cells are negative for this marker, whereas the endothelial cells are positive for this marker. So what I have shown you as these 4 criteria that allow the neuropathologist to determine, is this a grade 1, a grade 2, a grade 3, or a glioblastoma. When you have a grade 4 tumor, a glioblastoma, you have necrosis and pseudopalisading, mitotic figures, nuclear pleomorphism, and exuberant vascular hyperplasia. So these are the criteria we use to determine whether you're dealing with a low-grade tumor or high-grade tumor. I have to say that the WHO does not specifically point out to a very important concept, and we heard about this earlier today, that is the concept of glioma invasion. And that is really the big challenge for the neurosurgeon, the neuro-oncologist, is how to deal with the invading cells. And what this is basically these tumor cells at the edge of the main mass, which we discussed earlier are the T2 abnormality, the flare abnormality, which are infiltrating. And these pinkish elongated structures, these are myelinated nerve. So basically, these tumor cells are invading the surrounding brain, and you can, if you like, using an immunostain for something called neurofilament protein, doesn't matter what the name of this is, but you can highlight the axon, and you can see how these tumor cells are permeating in between this NFP, neurofilament positive axons. And so this is basically what one can see on the MRI. Next to the main mass, you have this T2 flare abnormality that corresponds to this infiltrative border at the edge of the tumor. And clearly, this is what Dr. Brem was discussing earlier about using the best possible technique to try to do a complete resection. Now, let's move on to the content. What is in the pathology report? Now, of course, you have the name of the patient. And I have to say, I tell my resident and fellow that this is a very important step. You need to make sure that the specimen belongs to the right patient. You need to take the time to compare the ID of the patient. You need to take the time to compare how is the label container to make sure that you're dealing with the right patient. That is essential. The content also includes, of course, the name of the pathologist, a short clinical history, the name of the referring surgeon and other physicians that are involved in the care of the patient, because these are the MDs that will be receiving the copy of the report. Any intraoperative consultation, what we call a frozen section. Sometimes the surgeon during the surgery is interested to know what kind of tumor he or she is dealing with. So we provide them with an intraoperative consultation, allowing them to plan further surgical approaches. Of course, it includes the diagnosis, which include type and grade, a macroscopic description, which corresponds to basically a description of the size of the lesion, the size, the appearance of the tissue received, but also a microscopic decision, which basically describes the cell type and features that we have described so far. There is also a comment or an addendum that first and often discuss previous pathology report if this was a re-operation, but also discuss the result of immunostain and molecular testing that will be done. So here is such an example of a patient that was recently operated in our institution. You have the patient, the address, birth date, all that, the accession number, the labeling of the specimen, the diagnosis, the comment describing all this, the macroscopic description, how big or small the tissue received was, the section taken, and of course the name of the pathologist. We have now also an addendum which includes the molecular testing that I will discuss now. So how does report impact the management? Of course, this plays a critical role in how the patient is managed. It is also allowing us to establish what's called a clinical pathological correlation. Sometimes what we see on the slide does not represent what is in the patient head. And this is due to a lot of things. For example, the surgeon might have just superficially addressed the tissue within the tumor, and we might not see, for example, necrosis that would otherwise have led us to make a diagnosis of glioblastoma and only allow us to make a diagnosis of anaplastic astrocytoma. So there is an issue here that's important. Correlating the X-ray to the pathology is essential. And of course, help determine treatment option primarily as a result of molecular testing. So molecular testing is essential. This is something that is more and more important in neuro-oncology. And my goal today is to tell you that if the tests have not been done at the time of the surgery, it can always be done if tissue is available. Tissue does not need to be fresh for this molecular testing to be done. And if surgery is done again, of course, if the tissue is not available from the previous surgery, this molecular test can be done on the re-resection. So in neuro-oncology, we have a concept of primary and secondary glioblastoma. When we talk about the secondary glioblastoma, we talk about a patient that had, usually the patients are younger, a lower grade tumor that over the years progressed to a full-blown glioblastoma grade 4. By contrast, we have patients that have what we call de novo glioblastoma, usually older patients, which have what we call primary glioblastoma. To the eye of the pathologist, the secondary glioblastoma and the primary glioblastoma can look identical. So clearly, it is the molecular progression and the clinical information that allows you to establish whether this is a primary glioblastoma or secondary glioblastoma. Early on, in the early investigation that were done in the late 90s, there was two molecular markers that were well characterized, p53 and EGFR. And the data indicated that patients that have secondary glioblastoma usually starts with a p53 mutation, whereas older individuals with primary glioblastoma have EGFR amplification. We'll discuss these two tests. But it's now clear that the progression from low grade to glioblastoma in the case of a secondary glioblastoma is much more complicated, and all of this mutation and chromosomal abnormality and imbalance and what we call loss of heterozygosity, we just mean that one copy of the gene is lost, all of this eventually can lead to a secondary glioblastoma. What I want to do today is discuss mainly three markers which have direct clinical implication. These include 1p19q, and Dr. Landolfi already mentioned this, IDH1, and MGMT. I will also quickly discuss EGFR and I will not have the time to discuss all of the other markers that could play a role in glioma progression and glioma genesis. So these molecular biomarkers have three main roles. A, they help us in the diagnosis. I will give you an example in a moment. They help us in discussing prognosis, and they help us in deciding on tailored therapy. So one of the really classical tests that is being done is a test known as 1p19q. And it is a cartoon I have prepared here to show you that we all get one chromosome for our mother and one chromosome for our father. In a normal cell, you have, for example, in chromosome 1, a short arm, which is called P for branch, petit, and Q for the long arm. So in a normal cells, you have 2 copies of 1P and 2 copies of 1Q. And the same thing is true for 19P and 19Q. In an oligodendroglioma, for example, you can have loss of 1p19 and one loss of 19q. So how this looks like, this is a classical way to look at this 1p19q. There are a lot of ways you can do that. You can do this by PCR, polymerase chain reaction. You can do this by fluorescent in situ ablation. I hope you see that in this case, for example, which is an oligodendroglioma, there are in the cells 2 green dots, but only 1 red dot. We morphologists, neuropathologists, like to look at FISH, fluorescent in situ ablation, because we can see in the tumor cell, we can actually see this loss of heterozygosity. But as I said, you can do this test using PCR, which does not allow you visualization, but still provide you with information. Now, why is this test important? 1p19q loss is associated with good response to therapy in oligodendroglioma. The exact molecular mechanism controlling the effect of 1p19q in 2013 is still unknown. So it's an extremely powerful tool, but yet we don't know why is it that it's such a powerful tool. MGMT, this sounds like a complicated chart, but it's actually very simple, and Dr. Landolfi already alluded to this. So basically, here, look at me. This is what's happening here. We have a chemotherapeutic agent known, for example, as temozolomide. This drug adds to the DNA of tumor cell something called the methyl group, the ME group. This interferes with the polymerase, which are enzymes that allow the cell to multiply, and therefore the cell undergo death. This is only happening when this enzyme, MGMT, is absent. In a normal cell, when the enzyme is present, the effect of chemotherapy is diminished because the MGMT enzyme is not silenced. So what we want to do in discussing patient therapy is to determine whether or not MGMT enzyme is functional or not functional. In the best case scenario, MGMT is absent, allowing the methyl group that have been added by the alkylating agent to basically lead to cell death. But again, if MGMT is in the cell, this methyl group are removed and the cell is rescued. This silencing is done through a process known as hypermethylation. I don't have the time to discuss all this today, but clearly this is an important test in neuro-oncology. And here are the two classical papers published in 2000 in New England Journal of Medicine, in 2005, and you can see that there is a pretty important effect not only on detecting and decided treatment approach, but also on patient survival. Now, IDH1 is really the newcomer, and this has a major impact in neuro-oncology. IDH1 is an enzyme that allows some metabolic substrate transformation in the cells, and when this enzyme is when the gene of this enzyme is mutated, the outcome of the patient is much, much better. This is a really ongoing international effort. But before I go into the effect and the importance of IDH1 on prognosis, I want to tell you as a morphologist, I welcome such a tool because when I have a question mark, is the patient biopsy showing tumor or gliosis? When there is such an immunoreactivity for IDH1, I know for sure that these are tumor cells. So this by itself has a tremendous impact on how we practice neuropathology. We had several cases before IDH1 was available to us. And we were very fortunate because we had access to this antibody that was made by Dr. von Deimling from Germany early on. We had sometimes cases where we couldn't decide whether the patient was basically showing a picture that was compatible with gliosis, which is a reactive, non-neoplastic process, or a neoplastic process. So once again, immunoreactivity for IDH1 confirm with certainty that you are dealing with a neoplastic process. IDH1 is identified in a very high frequency in secondary glioblastoma, whereas it's extremely low in primary. We talked about young patients eventually developing glioblastoma compared to older patients with primary glioblastoma. And 50 to 80% of WHO grade 2 and 3 astrocytic tumor and oligodendroma exhibit IDH1 mutation. So grade matters, morphology matters, but IDH1 matters. And it's now something that's been confirmed, and we are discussing revising some of the WHO classification scheme based on IDH1 profiling of the tumor. So here are some curves that show that in all groups taken into account, when IDH1 is mutated, there is a better survival than non-IDH1 mutated tumor. These are some data that have just been presented at ASCO last June, and you can see that in both GBM and anaplastic astrocytoma, IDH1 status is essential. Now let me conclude about this molecular testing by talking about EGFR. EGFR is an abnormality that has been implicated in a variety of tumors, not just brain, but colon and head and neck and pancreas and breast. In the brain, EGFR amplification, again, you can see here in red how many copies of the gene is available. Again, we like morphology here because we can see with certainty that this amplification is within the tumor cells. However, the impact of EGFR has been debated over the year, and I call EGFR l'enfant terrible of molecular neuro-oncology, because some papers have shown that EGFR amplification is associated with poor prognosis, but some papers have shown that there is no impact on prognosis. And some papers showed even that it was associated with a better prognosis. So clearly this test has not been fully validated, and clearly more studies are needed. One of my colleagues, Dr. Orbinski, has published a paper that I think is very important, which shows that the tumor that have no amplification or high level of amplification have a better response to temozolomide. So the tumor that are in between intermediate degree of EGFR amplification might be the tumor that have a worse outcome. So clearly this explains maybe why there was such a discrepancy between different papers looking at how EGFR is predictive of outcome. The take-home message is that you have to look at all these molecular markers together. You have to integrate them. And for example, the long-term survivors that showed 1p19q loss had no EGFR amplification. IDH1 mutated tumor, which I've just told you, have a better prognosis, but among those tumors that have IDH mutation, those that have a worse outcome lacked MGMT promoter methylation. So clearly you need to look at this together. You can look just IDH1 or just at MGMT. And clearly this points out to the importance of combining this testing. So in the future, and actually future kind of present, wish, you will take into account the clinical information you have on the patient, the MRI, the genomic, and the pathology. And we have clearly a lot of work to do. Genomic sequencing is obviously something that everybody is gearing toward doing, and I'm confident that this is going to allow us to understand this disease much, much better. So I want to sort of confuse the picture here and tell you that glioblastoma is not one disease. There are at least 4 types of glioblastomas. And molecular testing have allowed us to determine that there is a proneural form, a mesenchymal form, a proliferative, and a neural form. And these have different prognosis. A proneural form of glioblastoma is less aggressive than a mesenchymal one. And the TCGA, which is a national consortium, came up with this profiling, and you can see again here that IDH1 in the proneural confer a better outcome to this patient. Clearly, many molecular abnormality, P10, NF1, P16, all of these. But in conclusion, IDH1, 1P19Q, and MGMT are the only validated prognostic predictive marker in neuro-oncology. The prognostic of all other molecular change is at this point uncertain. IDH1 mutated versus wild-type tumor are biologically different entities. Clinical trial should be stratified based on this formation. Time has arrived where you don't look at 100 patients without molecular profiling, because I believe the yield of the information and the effect of the therapy on the patient really will be much better defined if you know to begin with what is the molecular profiling of the tumor. Targeted therapy requires concurrent molecular analysis of the tumor, analysis of relevant biomarker. You need to do this clinical trial knowing in advance what is the tumor features and characteristics. So in summary, what I have tried to do is to tell you that the pathologist has obviously a role in diagnosing, in establishing molecular profiling of the tumor, but in my opinion also in tissue banking. It is a critical role to establish the WHO grading system, and I have shown you some pictures that shows you what we see on the slide and what we take into account to establish that the tumor is a grade 2 or grade 4. I have pointed out what is the content of the pathology report and how it impacts the management, and I have taken some time describing some molecular tests. So thank you very much for your time. I just want to acknowledge my colleague in the Division of Neuropathology at NYU that have provided me with some picture for this presentation. Members of my lab, current and past members that have been greatly helpful. All of the NYU neuro-oncology team, which include everyone in our team that take care of patients, some collaborators at Johns Hopkins, and of course, support from foundation as well as from NIH that allow us to do some exploratory work. Thank you very, very much for your time.
Maybe this is louder. How long can a tissue sample be kept and still be effective to test again?
Very interesting and important question. So we had a case about 2 months ago, actually more than 2 months ago, early July, where a patient asked us to do MGMT on a patient on a specimen that was up to 1999, and it was fine.
Mine was done at NYU in 2001.
It can be done.
Can it be done?
Absolutely.
Okay.
For the 1P19Q,
That was done. It was negative.
we would need, but it was done, but if it would not be done, we would need also a tube of blood because we do it by loss of heterozygosity.
Okay.
But for MGMT, you don't need that.
Oh, I would like to do, well, I'll speak to, who would I contact? Call
Sure.
you?
Sure.
Okay.
You're my call.
Thank you.
What is the role of the CMV virus, do you think? And also, will it be part of the pathology report?
So I am very fortunate. My colleague, Dr. Mikolenko, before joining Dr. Peter Berger at Johns Hopkins, was in University of Alabama. And the PI of this CMV hypothesis in Birmingham. So she is looking in GBM, and I can tell you the high number of tumor specimens have CMV antigen in them. How this contributes to tumor progression, I would not be able to answer the question because it's not my area. But I can give you the contact info at the neurosurgeon in Alabama, and I'm sure he will be very pleased to answer your question. I have reviewed grants that have asked to look at how CMV contribute to glioma progression, but I can give you that information.
I have a question. We have a few patients who we got a second opinion on a pathology report, and the two reports are very different. First of all, how could that possibly happen? How could you not say that it's a glioblastoma and it's not a glioblastoma?
Yeah.
And what do you do in that case?
Yeah, I was expecting the question. So, first of all, we welcome second opinion. We learn a great deal from second opinion. Neuropathology world is a very small world. There is no one out there you don't know. We meet at meetings, we email each other. It's a very small world. These are friends and colleagues. What I like to say about second opinion is that there are small discrepancies and significant discrepancies. Let me address the significant discrepancies first. I think that if you got a diagnosis of glioblastoma in one institution and you get a diagnosis of a pilocytic astrocytoma in another institution, that's a major discrepancy. Of course, the pilocytic astrocytoma can be cured. So we've seen that, where a neuropathologist being, impressed by, for example, the nuclear pleomorphism, have called the pilocytic astrocytoma a glioblastoma. That we've seen that. That's a major discrepancy. And as I said, we welcome second opinion. From our own patient, when any one of our patients is asking for the second opinion, we always release anything that is available for the second pathologist to make his appraisal of the case. The minor differences is maybe that's what you're referring to, which are the more common differences. Have to do, for example, with people that have asked another opinion and have been given a diagnosis of glioblastoma in one institution and a diagnosis of glioblastoma with oligodendroglial features in another institution. That is highly depending on whether or not the second pathologist take into account the fact that glioblastoma can have a few round cells in them, and that doesn't make the tumor a glioblastoma with oligodendroglial feature. This is why the molecular testing is so important. This is why this will settle those minor discrepancies between pathologists. But again, second opinion are always important. I would encourage everybody to get a second opinion.
How do you go about getting a second opinion?
You call the clinician that provide you with the phone number of the division of neuropathology. You have to sign a release, of course, because you don't want the division to release your slide without you authorizing it. And you would have to provide us with the address of where you want the tissue to be sent, the slide to be sent. Now, I have to say one thing about this. If the second pathologist is interested to do stain that have already been done in the primary institution, I would recommend the primary institution to release those immunostains so that the secondary pathologist doesn't have to cut the tissue again. Because at the end, remember, you want to try to keep the tissue as long as possible. Why? Because down the road, you may have a novel treatment that requires, especially with targeted therapy, to determine whether an antigen, for example, is present or not present. You don't want to be in a situation where a tissue has been seen by 4 pathologists, and each of these 4 pathologists have done their own stain. That's, in my opinion, a waste of tissue.
Any other questions?
How routinely are molecular tests run on these samples?
So
In
We-
different hospitals and centers.
In our institution, every glioma is MGMT tested, IDH1 tested, and 1P19Q tested. Yes. I know the American Association of Neuropathology is trying to determine those numbers. I don't have those numbers yet.
I noticed on one of your slides you had the EGFR and EGFR V3.
Right.
Could you enlighten us as to what the difference is?
Sure.
Please.
So EGFR can be amplified. That's the epidermal growth factor receptor. The receptor for something called EGF, which is the ligand that binds the receptor. The receptor itself is amplified, causing a lot of changing within the cells, what we call cell signaling. But there are also situations where there is a mutant of that. It's called the EGFR V3 mutant. That's a mutation of that gene. So there are amplification and mutation. There is an analogous situation with BRAF, for example, where you can have mutation but also fusion. So the same gene can undergo different type of chromosomal abnormalities. Yes, but you could also have a V3 mutation in an EGFR amplified. It can go along, so you have to do both.
Okay, thank you.
Thank you very much.